myself. I should look directly in here.
I guess you should look.
Should I look at her when I talk?
When you're talking to her. She's
Yeah, I think we
asking
should
you-
look at each other.
She's
and
asking you the question.
Okay.
You know, looking into the camera doesn't really do any good. Okay. Do we have speakers? Okay, you can start whenever you like.
Good morning. I'm Vivette, Director of Renal Pathology at Columbia Presbyterian Medical Center, and I have been given the honor of interviewing Dr. Conrad Pirani for this video legacy series of the International Society of Nephrology. Dr. Pirani, I've known you since 1980 now, when I came as a second-year resident to your laboratory here at Columbia, and I know quite a bit about your career, but many of our viewers may not be as familiar with the early history of your life and career. Maybe you can start by telling us a little bit about something of your early days in Italy and how it was you came to study medicine.
All right. I come from what I could call an academic family. My father being a professor of chemical engineering at the Polytechnic Institute in Milano, Italy. And I always thought through my days in high school and junior college that I would study engineering because of my father being in the field. However, at the last moment I got a bit afraid because my mathematics was kind of weak, and I was afraid to be a student in the same institution where my father taught and not doing well. So I changed my mind and I decided to go for medicine. In other words, I was not a born physician. That was a decision taken at the last minute, really. And from then on, I followed my medical study, mainly with major interest in research.
Well, how was it that you came to leave Milano and come to the United States? Can you tell us a little bit about that background?
Well, I went through my medical studies and did actually some little research work as a medical student, as well as for my thesis, which is required for graduation from the Italian university. And then around 1938, in Italy, the fascist government passed racial laws similar to those which had been introduced in Germany a few years before. In other words, people of Jewish background could not enter the professions, could not work. So although I was able to finish my studies within a year after graduation, which was in 1938, I realized I couldn't do anything in Italy. I had to get out of the country. And so I opted for the United States, a decision which I think was the right one.
Did you know anyone in the United States at that time?
No, I didn't know anybody, although I had some letters of introduction, which ended up not being of much help, actually. But at any rate, I was able to meet some people shortly after I arrived. And then I had some people whom I knew, but not in the medical field.
I see. And when you first came, did you go directly to Chicago, or did you first
No, I was in New York. The first year I was in New York, and at that time, New York was crowded with medical doctors escaping from Europe, and it was very difficult to find a job. So my first job was that I replaced an intern who had become ill and be an ambulance surgeon for one of the hospitals in New York City for several months. And that was my first job in the United States, while I was looking for an internship, which I was able to find in Chicago.
Mm-hmm. I see. Now, when you first went to Chicago, you worked for some time, as I recall, in the U.S. Army Medical Research Laboratory. And is that where you...
No, before that, I had several years in Chicago, actually. I had 2 years rotating clinical internship. Mm-hmm. And at that time, I was still undecided whether to go in internal medicine or into pathology. My thesis in Milano to graduate from medical school had been in pathology. So perhaps that was a field in which I had a little more experience coming out from medical school. But after the rotating clinical internship, I was able to secure a residency in pathology at Michael Reese Hospital, who at that time, the Department of Pathology at that time, there was directed by Dr. Otto Safir, a renowned pathologist, especially in the field of cardiovascular pathology.
I've heard you speak of him many times.
Yeah.
He was a big influence on your career at that time.
Well, he was a superb morphologist, very precise in his training, in the training of his residency. Every morning, the residents had to have studied the surgical pathology slides and be ready to answer any question. And Dr. Safir in his office would ask,
I don't know that today's residents are so ready in the
what
morning.
did I think of this or that? And he was pretty strict in what he required of us.
I see. So you spent 2 years then
I
in a
spent
rotating
my
residency?
3-year residency
3
in
years.
pathology at Michael Reese Hospital, which was exclusively anatomic pathology. I did not elect to take any training in clinical pathology.
I see.
And at that time, most of my work was in cardiovascular disease, which was the great specialty of Dr. Safir. And I worked mainly with the assistants and residents in the section on cardiovascular disease of the Department of Medicine. And I published several papers in heart disease at that time as a resident. One of which was with Dr. Langendorf, who became a renowned electrocardiographer on the heart in uremia, for example, and also on infarcts of the heart, subendocardial infarcts of the heart. So my interest was, and I still thought I would become a cardiovascular pathologist or perhaps a clinical cardiologist. I was still a bit uncertain whether to stay in pathology or to go into medicine.
What made your decision to enter pathology then? What was the deciding factor there?
I like the field, and Dr. Safir had been very nice to me. And so I remain in pathology. However, for a moment I had, as I mentioned, some doubts. Actually, for a period of a couple of months, I attended a clinic on renal diseases, which was directed by Dr. Sternheimer of the Sternheimer cell fame. And he was, again, very precise. He required that every clinician working in that clinic should first look at the freshly voided specimen of urine of the patient before examining the patient, which I still think is a very good idea, although I'm afraid it's not.
I don't think the art of urinalysis
it's
is
not
so
done
well
any
done
longer.
anymore. No. So then you first started doing urinalyses before you looked at renal biopsies.
Yeah, because really, if you think about it, urinary sediment, as Eddie said many years ago, is much more likely to give you an inkling of the type of disease which affects the kidneys. In other words, if you see red blood cells, chances are the disease is in the glomeruli. If you see white blood cell, chances are the disease is in the interstitium. And if it is tubular cells, that means there is the degeneration of tubular cell that you may see at times in the nephrotic syndrome, as oval fat bodies, at times in acute tubular necrosis or severe damage to the tubules. Now, renal functional tests won't tell you anything about the type of disease. They'll tell you about the overall function, but they're not qualitatively. It's not very helpful. Are not very helpful.
Now, it's my understanding you had some experience in renal physiology from the work that you did at the U.S. Army Medical Research Laboratory during the war.
After I completed my residency, I was able to secure a position as instructor in pathology at the University of Illinois College of Medicine in Chicago. That is the first academic step. And at the time, the department was directed by Dr. Granville Bennett, who was mainly a bone and joint man, very good in his field. And the associate director of the department was Cecil Krakauer, who had done some excellent work on sodium and cardiac hypertrophy, and more especially on the isolation of glomeruli and identification of nephritogenetic antigen in the basement membrane. So it was a good department at that time, a strong department. And Dr. Bennett had promised me that you'll find some money for some research. And however, he was never able to do so, and I got a bit discouraged until Dr. Bennett called me and said, look, I realize I promised you to find some money for your rabbits, but I cannot find any money. However, I have received, somebody has contacted me saying that they need an experimental pathologist at the United States Army Medical Nutrition Laboratory right here in Chicago. Go and see what they have to offer. And if you should accept that position, you can still remain on the staff here part-time to help us teach in the course at the second year level. And so I did, and there was a lot of money available at the Army, and this was a laboratory which was very well organized, was directed by a physiology Dr. Johnson, who was perhaps one of the few remaining human physiologists in the United States, who knew what the significance of fatigue is in man, not in rats. And the other man, remarkable man in the department, in the laboratory, was Dr. Robert Clark, who was director of clinical investigation for the lab, and he was particularly interested in alcoholism and nutrition.
I see. So that's how you first met
He was
Clark.
studying this problem in troops, in soldiers, and in Veterans Hospital, and so forth. And the third very capable, very competent man was Stanley Levinson, who was a metabolist man. He was a surgeon originally by training from Harvard. And he had originally studied the Harvard, the famous coconut fire, the nutrition problem of people who have been burned and who lose a lot of proteins, have serious nutritional problems. Anyhow, this was a very important period in my life, in my scientific life, because the laboratory was not a large institution. We were in I was then in close contact with a physiologist, a man interested in metabolism, and a man interested in clinical medicine. Whenever we had projects to carry out, we consulted each other and criticized each other, and I learned a great deal. Now, in that period, actually, I remained in that lab for about 5 years. That was the time of the Korean War. I did a lot of work on wound healing with Stanley Levinson, particularly on vitamin C, and then vitamin C is stress phenomena, and vitamin C in relation to the adrenal cortex. And I think this type of experimental work I did there was of considerable help to me in
You had to do careful histopathologic grading, isn't that right, of these lesions in wound healing?
Well, the functional significance of lesions, the factor involved in lesions, and perhaps one thing I should mention in addition is that as I was studying wound healing, And we took specimen at regular interval after we had inducted wounds in the experimental animal. We took specimen at day 2, at day 4, at day 7, at day 10, at day 14. And there were different microscopic findings in these wounds depending on the state of nutrition. And in order to compare, to reconstruct the evolution of the healing process under normal condition or under a condition of nutritional deficiencies, we had to quantitate the different changes that one saw in the wound area and compare day 2 to day 4, day 4 to day 7, and so forth and so on. And this gave us something that you could actually put on a curve and give you a much clearer understanding of what was going on. Incidentally, that was one of the reasons why later, several years later, I instituted the same method in the examination of renal biopsies.
Although we didn't do so many serial biopsies, did we?
Yeah, when we used, they used to take serial biopsy, yes. But also in order to compare semi-quantitatively the severity of the histologic finding, histopathologic findings with the renal functional data.
Yes, it taught you to be very precise
So
with
you
your
had
observations
to be
and
more
to correlate.
precise and to try
with the
to
functional.
quantitate or semi-quantitate in order to have a better understanding of the significance, functional significance of the lesions.
Well, let's turn a bit to those early days at the University of Illinois. I know in 1952, Kark and Murky were perfecting the technique of percutaneous renal biopsy that Iversen and Brun had introduced in Denmark, and that you became a very integral part of that team. How was it that you came to work with them originally and that these renal biopsies became entrusted to you?
So I went to this Army lab at the end of 1947, and in the spring of 1952, the character of the laboratory changed completely. And actually the laboratory was, shortly thereafter, was moved to Denver, Colorado, and I didn't want to move from Chicago. And Granville Bennett, Dr. Bennett, in whose department I still was part-time, offered me an associate professorship. By that time I'd published quite a bit, mainly experimental work. And so I went back full-time at the University of Illinois in 1952. And shortly thereafter, Bob Kark, Dr. Robert Kark, had become interested in renal diseases, although originally he was a man interested in liver disease and nutrition. And one of the reasons he became interested because, as people have written about it, is that once in a while when he was taking a liver biopsy, he got kidney tissue. And absolutely nothing untoward resulted. No damage to the kidney, functional damage or anything. So he felt a renal biopsy could be taken. And also about the same time, in the same period of time, Dr. Iversen and Dr. Brun, Klaus Brun in Copenhagen, Denmark, had developed a system to take renal biopsies. And the reason they developed the system was for the same reason that Dr. Kark had become interested. They also, once in a while, Iversen, instead of taking liver biopsy, Iversen originally was a liver man, they obtained renal tissue. So they felt the method could be applied to the kidney. And it was, and Kark and Murky was then a young resident, modified the system in part with ideas from Perez Ara, who was a Cuban pathologist. And the renal biopsy then was taken with the patient lying down instead of being in the sitting position and so forth and so on. The method became much more precise, with a much better yield of biopsy specimen. So essentially, they modified the method. They developed their own method, Kark and Murky. And then somehow the renal biopsy came to me for study.
How were you selected among the pathology team there?
Well,
Did you
this
express an
was
interest?
still, I'm not sure I have an answer to that. But Dr. Krakauer, who was director of surgical pathology at that time, was a very busy man involved in other studies. Surgical pathology was a very busy service. He felt renal biopsies was too much, that he could not handle this problem. And Bennett called me up and said, I'm sorry. He practically apologized. He said, but I have to give you this responsibility because Dr. Krakauer does not have enough time to take care of it. So the renal biopsy came to me by accident, really. Now, it may be that Bennett knew that I had worked in the past with Dr. Kark before, and that I had a little experience on renal functional test because I had worked on a project at the Army Laboratory in relation to dextran and renal function. For that reason, now, what is interesting looking back, that when I got this biopsy, I thought it was an imposition. I did not realize at all what I was getting, except additional work that I did not have much time either to take care of. I certainly did not realize the opportunity that I was being given. I don't think Dr. Bennett either realized the possible future of renal biopsy. So I, nilly-willy, I had to take, Dr. Bennett was the chief, I had to take this responsibility. I did the best I could. In my spare time, I was very busy with the autopsy service. At that time, the staff pathology also rotated in the cytology service and also in surgical pathology from time to time. So that was something extra. And it took me several years before I began to understand what I was looking at.
Well, in the beginning, there was tremendous skepticism about, first of all, the safety of doing renal biopsies, and second of all, the value of doing these biopsies in terms of diagnosis.
That's right.
Can you tell us a bit
there
about
was there was some criticism, some opposition. Urologists didn't like the idea because they felt internists was entering in their field. Also, they did not like to be called if some accident would happen.
Mm-hmm.
And so that...
Well, I'm reminded of a story that you once told me about Kark's reply to an editorial that appeared in Lancet in around 1955. Yeah. The editorial has said something to the point that it's of as much value to treat a patient with nephrotic syndrome initially with cortisone as it is to do a renal biopsy, and probably a far less detriment to the patient because you'll get the same amount of information and it won't do the patient any harm. And he wrote a rebuttal to that, I remember, at that time, but there was really tremendous
you're
skepticism.
Absolutely right. There was a very critical editorial that appeared in Lancet, but I think a few months later, Kark answered also in an answer published in Lancet, in which he pointed out that renal biopsy contributed in a significant manner to the understanding of renal disease. Now, the objection to biopsy was that two major objectives. One was that it was felt information that pathology would get was only of academic interest. And second, in any case, there was no therapy anyhow. So what was the sense to understand better? Now, this type of reasoning, if we follow that type of reasoning, no progress would ever be made in medicine. It's just like not searching for antibiotics because a bacterium had been isolated or something. So new methods have to be evaluated, but certainly, certainly at that time, I did not realize what future renal biopsy would have had. And it took a while.
I think there also was a tremendous degree of skepticism about how one could draw conclusions from examination of so few glomeruli or so little renal tissue.
That's
how
right.
could it be representative? Because the pathology up to that point had all been
very important.
autopsy-based.
Very important that the specimen was so small, being a needle specimen, that many people felt was totally inadequate to draw conclusions. Which we made a very simple study on that by comparing the needle specimen with the larger areas from the same kidney obtained at autopsy, and found there was an excellent correlation, not only in type of lesion that you would see, but also essentially in the degree or severity of the disease. And however, you had to have, in our opinion at that time, at least 5 glomeruli and adjacent cortex. To less than 5 glomeruli. Now, this study was repeated with much more, many more cases by Dr. Chomet and others at the Veterans Hospital in Chicago, the Westside VA Hospital. And this confirmed those results. So, in other words, you could obtain very good information in practically all diffuse renal diseases. We knew that in pyelonephritis would not, the biopsy, needle biopsy may be inadequate, but then even a larger specimen may be inadequate in pyelonephritis.
You know, I always
and more
remember,
seriously in focal segmental glomerulosclerosis.
I was always very impressed as a resident by the story you told me about a paper that you once submitted showing the foot process effacement in a patient with minimal change disease and how on repeat biopsy there was restoration of normal foot processes. And I believe you had something like 7 glomeruli to look at by electron microscopy in the first biopsy and 5 or so in the second. But when this paper was submitted for review, the reviewers criticized it for the small number of glomeruli that had been studied and said that certainly no conclusion could be drawn based on the study of so few.
Yeah, that was a sort of famous episode. You see, the problem of adequacy, we thought we had resolved that problem with our studies by light microscopy. And then emerged again when electron microscopy was introduced. Because, of course, in the little bits of tissue left for EM, often we could find only few glomeruli. And the case you're mentioning was a case in point. Actually, we had studied we were much aware of that. We studied, in that particular case, all the glomeruli. There were 7 in the first biopsy and 5 in the second biopsy. And we found very consistent lesions. So there was no question that the interpretation, the adequacy was demonstrated, but the journal felt still that the sampling was inadequate. And the paper was rejected by the journal. And however was accepted later, the first author is now a prominent cardiologist in Rome, Italy. His name is Giuseppe Folli. And we demonstrated actually what perhaps was most important in that paper, that the lesion of minimal change disease are completely reversible, and the glomeruli may return to entire normal structure after therapy with cortisone. And that was these 2 biopsies represented. One was before therapy, and the other 2 months later after therapy, or 3 months later, after the proteinuria had decreased to practically nothing. So you see, that's perhaps one of the great merit of Clark and Murky was that they insisted at that time on the importance of sequential biopsies. They were the first to really use sequential biopsy. And we demonstrated reversibility of lesion, not only minimal change disease, but in preeclampsia, eclampsia. In later with John Louis in post-streptococcal glomerulonephritis. And really, repeat biopsy are essential to document not only the possibility the lesion may revert completely, but also to see the effects of therapy, to evaluate the effects of therapy. And this is something that is now become more difficult to pursue because of ethical considerations, I guess, that it's very difficult to repeat a biopsy if the patient is better. Repeat biopsies, as a rule, are done in a number of diseases, including lupus nephritis, when the patient gets worse, but not when it gets better. And if you think about it, it's still one of the avenues of future research. For example, in acute post-streptococcal glomerulonephritis, you have an increased cellularity of the glomeruli in the acute phase, with increased amounts of mesangial matrix being produced. And within months, the cellularity in the great majority of cases has disappeared, the hypercellularity, and also the mesangial matrix, which had increased in a significant manner, disappears. So it's not true necessarily that matrix increase, mesangial matrix increase, or thickening of basement membrane is truly an irreversible lesion. Apparently, if the cause is removed, such lesion, at least to some degree, can be reversed. Now, what does cause the reversion of this lesion? That's the question I should ask. Are these perhaps enzymes coming from inflammatory cells? Or I don't think there has to be something more than just the decrease of immune complex in the circulation. This may cause the increase in mesangial matrix, but not the disappearance. It would be difficult to visualize that. So again, although I understand the ethical reason why repeat biopsy are not practiced today as they used to be, I still think it would be very important to understanding the evolution of renal disease to repeat the biopsy under inappropriate cases, in appropriate situation.
I'm rather interested to hear from you a little bit more about how the team of Kark, Murky, and Pirani developed in those early days, and later Vic Pollack became a player. Can you tell us a little bit about how you developed your association and what each individual brought that was unique to the partnership that made it so successful?
Well, once the biopsy were given to me for quotes and quotes interpretation, which I'm sure was wrong in the first year or 2 years in most cases, obviously contacts with Kark and Murky became very close. And actually that's one of the most satisfactory things in renal biopsy work, that the contact with clinician is very close. I found that the renal and the clinical nephrologists still today have an active interest in renal pathology, something which I'm not sure is true in many other fields of pathology.
I agree with you, and I think they have more knowledge of renal pathology than the average surgical pathologist by far.
That's correct, absolutely. They have more knowledge of renal pathology than most what other pathologists know. And so they came immediately to take a look at the biopsy. As soon as the slides were out, they would call me, are those slides ready? I want to come and take a look. And we developed a very close collaboration. And sometime very stimulating observation. And I can tell you a story about this. Once I was a young man with the nephrotic syndrome, and I looked by light microscopy. At that time was before electron microscopy. I could not see any changes whatsoever. And I reported mistakenly, as it turned out to be essentially normal renal tissue, I wrote. And the following day, I heard the booming voice of Bob Clark. He was a big man. He still is a big man. Down the corridor saying, "Where is Dr. Pirani?" And he came into my office and said, "Don't give me that stuff, that this is essentially normal renal tissue. That tissue cannot be normal. The patient is losing 10 grams of protein every day. There has to be something wrong with those glomeruli." And I said, "I don't see anything." And he looked at that and he couldn't see anything either.
I imagine he couldn't.
At that time, I said, well, perhaps an electron microscope might be of help here. And sure enough, from then on, we started discussing this, and eventually we came up with a little money to use the electron microscope. And that, of course, revealed the widespread fusion of food processes or effacement of food processes in whole glomeruli. But that's the way it went. There was a continuous exchange between clinician and pathologist.
Who was the
In my
major?
observation, they did not make sense to them. They did not hesitate to tell me, believe me.
When did Vic Pollack join the team? At what point was it?
Pollack came 2-3 years later. So the first biopsy came out in 52, late in 52, and Pollack came on board about 55, I think, or late 54. And Bob Clark had a lot of connection, not only in South Africa, where he came originally from, but also in England, where he had done postgraduate studies. And for a period, we had a large number of a series of research fellows, all from the Commonwealth, British Commonwealth, whether they were from Canada or England proper or Australia, just name them. And the clipped British accent or South African accent or Australian accent, I learned how to recognize the different intonation of the English language, plus my Italian accents. So the students used, there was a lot, they were kidding us.
I'm sure your accent stood out among the group.
Our accents, yes.
Well, how was it that you came to choose the areas of study that you concentrated on? I'm thinking, for example, of the main interests in lupus and toxemia.
The first major interest was, the first major areas I think were suggested by Dr. Clark, I believe. I'm not entirely sure about this, but I think he had a major interest in the nephrotic syndrome, and mainly originally because of the nutritional problem of the big loss of proteins in the urine in the nephrotic syndrome. So the nutritional problem of nephrotic syndrome intrigued him a lot, and so we studied a large number of patients with nephrotic syndrome and actually wrote a big paper about the multiple causes, multiple different diseases of the nephrotic syndrome. It was not obviously, it was just a syndrome. It was not a single disease. That became quite clear. And actually the paper I believe, that fully confirmed this. And that, in other words, clinical studies alone, even detailed laboratory studies alone, could not identify the different diseases. And still today, we have problems, I think, although I think clinical nephrology become much smarter. And perhaps not as many renal biopsies are taken today as they used to. But pathology becomes smarter too, so they know how to interpret the biopsy better, perhaps. Well, that was the first major area, and the second major area was lupus, and the reason on that was lupus, because of the finding of the LE cell, the disease was being recognized much more frequently now with much greater degree of accuracy. And obviously the renal involvement was a very serious problem in lupus, and perhaps one of the major causes after infection, perhaps of mortality in lupus patients. So it was felt that for that reason, plus the possibility of using cortisone. And although Merck started the work on lupus, Pollack took it over really eventually. And we wrote a number of papers. And Pollack was really the man who realized that in order to, so to speak, break the back of lupus nephritis, you needed high dose of cortisone. Was not enough to have. And also, we realized something that unfortunately is not done yet, that the earlier you treat, the better off you are. You should start treating lupus from the earliest lesion possible. In other words, you should perhaps biopsy all patients with lupus, as long as they have minimal urinary findings, because that's the time to treat and perhaps prevent evolution to serious renal disease. And there is evidence for that, that can be done. If you wait when the disease is very severe, the treatment may slow down the evolution, but eventually whole glomerule will become sclerosed and the patient will end up in chronic renal failure. But there is evidence in the experimental animals, certainly, that you can control the disease if you treat early.
For those of us studying renal pathology as novices today, we take for granted right away the WHO classification of lupus nephritis as a fait accompli. And it's hard to imagine, I think, the confusion that existed in those early days about the classification of lupus. When in your view, were the different forms first clarified, and what role did you play there? I'm speaking in particular about the mesangial form and the membranous form. There's a lot of confusion about these.
This came on very gradually as I looked at more and more biopsy from lupus. That is that the presentation of the patient with renal disease was based on a variety of renal lesions. In other words, the renal lesions were very pleomorphic. So we saw patients with minimal mesangial changes, a patient with membranous nephropathy, a patient with focal segmental glomerulonephritis. One of the first cases I had was a focal segmental necrotizing glomerulonephritis. And in my ignorance, I felt that I knew the patient had lupus, but I felt that possibly was due to bacterial endocarditis. That looked to me like focal embolic glomerulonephritis. And I felt perhaps this is a bacterial endocarditis, perhaps superimposed on Liebman-Sachs.
Well, this was one of the most difficult things about renal pathology. The idea that one lesion can have many possible etiologies was really was really a new concept that took some time to be accepted.
In other words, it's not only that different diseases cause different lesions, but the same disease can cause different lesions.
Or one lesion can be caused by many different diseases.
That's right. That's a very important concept that evolved from those studies. And but in fact, it took many years of my work, plus the work of many others, to gradually unravel the complexity of lupus nephritis and to recognize there were certain patterns. And these patterns actually tended to persist as such. Others did not persist. They changed character with, especially after therapy. But so that gradually a classification evolved. And this really was only in part my work, and many others contributed to this. And eventually a classification evolved that is now widely used. Together with that, we clarified the fact that I believe, and others did too, that there were lesions which were active, we called active, that were potentially reversible, and potentially reversible under therapy, and other lesions which were very slowly progressive and they were not reversible, chronic lesions, inactive lesions. And this is very important in the to guide therapy, because obviously it's hopelessly glomerular sclerotic. Therapy is not going to do, present-day therapy at least, is not going to do much.
Yes, I think it was understood intuitively, even at that time, that there were reversible and irreversible lesions in every condition.
And again, serial biopsy were very important here to clarify some of these concepts.
Now, as I look back at that period and dividing your career from the early period into the middle period, I think a defining moment was the Seba Symposium of 1961, which really was a monumental meeting in terms of putting renal biopsy on the world map and convincing the medical population that renal biopsy had a value diagnostically and therapeutically, which led to its acceptance around the world. What are your recollections of that meeting, and who were the players?
Well, that's probably the best meeting I'd ever attended in my life. And the reason was so excellent was there was a limited number of people in attendance. I think the total number was less than 30. And there were 6 or 7 pathology, and the rest were clinicians, clinical nephrologists. And there was, the meeting was conducted at a leisurely pace. There was plenty of time for discussion. In other words, 3 or 4 papers were presented a day. And there were no 10 minutes papers. Each paper was presented in half an hour, 40 minutes. There was half an hour for discussion. And also, it was clear that the clinician and the pathologists for that period, for that time, were very well informed on the field. They were knowledgeable. Clinician asked very intelligent pathology questions, and perhaps vice versa.
Who were the pathology representatives? I know there
The
was Jennings,
pathologists were
Heptonstall, yourself.
Heptonstall, who talked on focal glomerulonephritis, McCluskey, who talked on, I think, acute post-streptococcal glomerulonephritis. There was Mowat, who talked a bit on membranous. He was the one, Henry Mowat from Toronto. And who else was there?
I think you had Jennings.
And Rene Habib, who talked on the nephrotic syndrome and membranoproliferative glomerulonephritis. Among the clinicians, there was Kark and Bourget and Brun, of course. Iverson, unfortunately, had been ill, so he could not attend. And then the people from Sweden and so forth and so on. And there were, several people from England, of course, as well. Black, among others. Was a very good meeting. Now, the chairman of the meeting was the man from Hopkins, the chairman of pathology.
It was Arnold Rich, no?
Hmm?
I thought it was Arnold Rich.
Arnold Rich. And he was not too enthused about the future of renal biopsy. But many others were enthused, including myself, and I believe the end result was that this meeting, which was essentially based on the experience on many people over a period of almost 10 years, perhaps 5,000 biopsies had been seen. Really, that's the meeting that launched renal biopsy, made it realize that even today, with much better clinical diagnostic method and so forth, still renal biopsy is essential in many, many cases.
And in English style, I think it helped to have a little sherry in the morning and a cup of tea in the afternoon. Certainly helped the discussion.
Yeah. that was very, very friendly, very helpful, very civilized. That's right. The meeting today, this 10 minutes presentation followed by 3 minutes discussion, one after the other.
With a timer.
Are not very productive, I don't think.
It's not the same pace.
No, you should take your time in discussing things.
But what was it that made the Chicago area such an important focal point for renal biopsy?
Well,
it's, you know, when you consider how few places in the
we
country
were
were doing
lucky
them.
in Chicago, I guess, that at the same time as Clark and Merck and Pollack and myself did our work at Illinois, Dr. Earl and Dr. McCluskey, no, not McCluskey, Dr. Jennings in Northwestern were doing some very good work. They study particularly post-streptococcal glomerulonephritis and membranous glomerulonephropathy, and they did excellent, very good quality work, I think. And Ben Spargo at the University of Chicago also was very active at the same time. Actually, for a short period, we met once a month to exchange views. And this was very useful in many ways, and both from the technical aspect to improve our technology, as well as from the interpretation and interpretative problems.
Was there a feeling of competition between you,
And there
or
was
was there a
certainly a
certain
feeling of
collegiality?
competition. Who had seen the most biopsy? That was a bit of a joke, actually, but the fact is, you know, we're competing against each other in the field. There is no question about that. And at the same time, there were other groups very active, of course, elsewhere. So perhaps Rene Habib in Paris was very active. Klaus Brun and his group in Copenhagen, after a few years, became somewhat less active, but still they had produced a number of histopathological studies on renal biopsy. And
As you look back, Dr. Pirani, which of the renal pathologists who were prominent in that period do you think had the biggest impact on you in terms of your thinking?
Well, it's very difficult to say who had the most impact. Really, I would say that the major impact, the man who straightened out our ideas, came a bit later and was Robert Eptinstall. When he published his book in 1966, the first edition, and this was a one-volume book, all written by Dr. Eptinstall, no multiple author, and was beautifully written. He had clarified many ideas, including those originally expressed by some authors. In other words, he clarified what other people have written, perhaps in somewhat confused manner, including some of my own paper. And this book...
We could all use such editing, I'm sure.
This book became the Bible, if you will, was the original modern source of accurate renal pathology. Now, however, at that moment, don't forget that now immunofluorescence and electron microscopy have been in use for almost 5 years already, perhaps even more. So because until electron microscopy was not used for several years, the structure of the kidney was not really completely understood. And perhaps even today there is something to be learned through ultrastructural studies. And immunopathology, which was mainly McCluskey, Dr. McCluskey in this country, in the United States, to be a leader of, also clarified a number of problems which would have been impossible to clarify by other methods, obviously. So at that time, the book of Eptinstall really played a major role in stabilizing, in clearly expressing our knowledge of renal pathology.
Well, when I think of it, even in 1980, when I first started my studies, it was my Bible.
Yeah.
As well.
So he played a major role. And
did you have much contact with Rene Habib?
Yes, we have had much contact. He started at the meeting in Seba, and then I went to the L'Hôpital des Enfants Malades in Paris, where I met in 1961 for, again, Dr. Ambourget, and obviously she is a very accurate observer, very precise, detailed observer of the pathology of renal disease, and published very important papers based on very large number of cases, which is also very important to establish the reliability of results. So Rene Habib was certainly played a major role. And others, from different parts of the world. Priscilla Kincaid-Smith played a role, especially in relation to analgesic nephropathy.
You went to study with her for some period of time, didn't you?
I'm
Or you
sorry?
visited Australia at one point in your career?
There was a very common disease in Australia. That's one of the mysteries not really being ever clarified to the best of my knowledge. Why that disease was so much more common in certain countries.
But I'm saying you visited her in Australia, didn't you? At one time?
Priscilla asked me to come down for a few weeks to work in her department. That was in 1970. And I spent a month there reviewing biopsy. You see, she's obviously a clinician, but she also does her own renal pathology. So you wanted to check with a renal pathologist who is not a clinician if what she was looking at was accurate or not. And I'm not sure I helped her a lot, frankly, but she certainly was a very pleasant period of work. They kept me busy, kept me hopping, giving lecture from Adelaide to Brisbane to Sydney. I visited most of Australia. And see, we had also a Dr. Jim Lawrence, who is retiring actually this year, who became probably one of the most important clinical nephrologists in Sydney, who had been a research fellow of ours in Chicago. So he was in Adelaide originally, so I visited him in Adelaide. And so that was a nice contact.
Well, certainly there was a large network that was growing of exchange between renal pathologists. But up till that point, there really was not a common source of dissemination of knowledge, I imagine. There were not annual meetings that you could go to in those early days to exchange
I'm not sure
views.
I understood the question.
In the early days,
Yeah.
I'm saying in the early 60s, before the International Society of Nephrology and the ASN came into existence, there were no annual meetings where you could exchange views.
That's right.
So you had to
Yeah,
maintain
because
personal
you're
contacts.
absolutely right. The International Society of Nephrology actually was founded before
It was about 1961,
the
I
American
guess.
Society of Nephrology, I believe. Ambourget was the first president, and the first meeting was held in Evian, and the second one was in Prague in '63. The first one was in '61, perhaps,
I think so.
or '60.
Mm.
And the American Society was, I think was founded about the same time.
About 66, 67.
Yeah.
Neil Bricker. Tell me that, Dr. Pirani, as you look back, what do you think has given you your biggest satisfaction in your career? As you look back and
Well, a number of things.
survey what you've done.
Number of things. It's difficult to say which one is more important, really. I think one thing I enjoyed the most, really, is the close contact with clinician. As I mentioned before, clinician, even to this day, still come down and want to look at the biopsy themselves together. And this is vital, incidentally, because as most people know today, that a diagnosis of renal disease is a combined diagnosis, a clinical pathologic diagnosis. So at this, you feel you're doing something for the patient, that you really are a physician after all. You're not just somebody buried in a small room in the laboratories. So that gives me a great satisfaction. Now, of course, other things, I love to teach, so I taught a lot about renal pathology. I gave short courses for the International Academy for many years. I participated in the long courses. I gave the big slide seminar of the American Society of Clinical Pathology together with Robert McCluskey, and which was a very satisfactory experience in many ways, although perhaps was a bit too complicated for most pathologists.
You gave a short course for how many years? It was 10 years that you gave a short course,
And
wasn't
then
it?
we established a course here
Yes.
at Columbia that Dr. Dagat is in charge, that you are in charge now, that is now in its 20th year,
That's
I believe.
right, this year.
And also a similar course was established at my suggestion in Bergamo, Italy,
Where there is a lecture given in your honor.
where Dr. Bertagno has been a pupil of mine. He is in charge of that course, and Dr. Remuzzi is director of the institute there. Now, then it's difficult to put these things in order. So teaching gave me great satisfaction, and another major source of satisfaction was the number of excellent fellows, both men and women, that I've been lucky enough to have in my laboratory over the years. And many of them have done excellent career. There are several in the chair of pathology from Jerusalem to Prague to Oklahoma.
Can you name a few for us?
Well, Dr. Rosenman, Elise Rosenman, is head of pathology at the Hadassah Medical School in Jerusalem. He spent a year with me in my careers, and he did much work on renal vein thrombosis, major paper on renal vein thrombosis. Dr. Stejskal, Joseph Stejskal from Prague, he spent a year with me and did what I think is a very important piece of work that perhaps should have gotten more recognition. He is retired now, but he was head of one of the two medical schools in Prague. Mm-hmm. He did work on discontinuity or gaps or perforation, call them what you like, of the glomerular basement membrane in glomerular diseases. There is no question that some diseases have perforation, others don't have perforations. And the exact clinical significance of this in terms of hematuria and leukocyturia and so forth, and the other, and significance in terms of progressive damage is still not perfectly clear. And it's a problem that should still be investigated. Now, Dr. Silva is chairman of pathology in Oklahoma. You are director of renal pathology at Columbia.
At least for the time being.
And several others that, for example, Dr. Manaligod, originally from the Philippines, who perhaps was the first to help me out with some work in pathology, to help me out with some work on lupus. He's now acting chairman of pathology at Illinois. Seymour Rosen was a resident in Illinois. We worked together on a couple of projects on renal biopsies, and I believe he's head of surgical pathology, an associate professor of pathology at Harvard. He's head of surgical pathology at Beth Israel in Boston. And he has done some excellent work after he left my lab, especially in tubular function. Mm-hmm. And because most of my work, of course, was on glomerular diseases, much less involved the tubules and the interstitium.
Well, the glomerular